Good morning, everybody. Megan, you're right, that never gets old, and I'm always going to stand here and wait for it. I'm not from the South, but I'm going to go for it. Thank you so much for the opportunity to be here today. Thank you to May and Megan and the APSF Planning Committee. This is a real privilege. Again, I'm Meg Rosenstein. I wear a bunch of different hats like many of us in this room. I am the Director of Obstetric Anesthesia and Associate Chief Medical Officer at Overlook Medical Center in Summit, New Jersey. I also have the privilege of being here with my partners from Napa, with whom I get to have some great quality endeavors. And I'm really excited to be here to share with you some components of our quality improvement journey in reducing maternal hemorrhage. I'm not going to lie, I was nervous when May asked me to do this talk because the science that I'm talking about in this area, this isn't new. Now, that doesn't mean I'm not incredibly grateful to my peers, many of whom are in this room, who have worked tirelessly to define best practice. But what my talk really leans into is change management, how we align diverse practices, diverse providers to executing that evidence-based best care. Next slide, please. Okay, perfect. So before we dive into anything, I have no disclosures. This work is IRB waived under quality improvement. And to the right, you'll see a picture of Overlook Medical Center. That is my home for 16 years. She is very pretty at dusk, I have to say. Overlook is a community intensive perinatal center. We had roughly 2,200 deliveries last year. We are small. We are one of 7 Atlantic Health System hospitals, 5 of which have maternity centers. Combined together, those Atlantic Health hospitals deliver roughly 10% of the babies born to New Jersey's birthing patients. So collaboratively, we have an opportunity for significant impact, and due to some recent partnerships, I expect that that number and our reach in New Jersey is going to increase pretty monumentally. Okay, so moving on a little bit about New Jersey. Next slide, please. Okay, so New Jersey has a pretty difficult history of poor maternal outcomes. As recently as 2019, New Jersey ranked 47th in the nation for maternal deaths, and it has one of the widest racial disparities for both maternal and infant outcomes. In 2019, a Black woman in the state of New Jersey was 7 times more likely than her white peer to die from maternity-related complications. 7 times. So there's been tremendous work in this area. Thanks to programs like Nurture NJ, the expansion of Medicaid coverage to a full year postpartum, and legislative support for both maternal and infant health, New Jersey's making crucial strides. We are far from done, but we're headed in the right direction. One important component of the Nurture NJ program I've got demonstrated here, and it's transparency of and accountability for site-specific health outcomes data. So to that effect, the New Jersey Department of Health has released the Maternal Health Hospital Report Card. This update was released in February 2024, and it included data from 2018 up through 2022. We'll see a recurrent theme. Everything when it comes to state health data in New Jersey is slow. But what was really powerful about this tool is New Jersey's healthcare consumers now had a very simple way to log in and to compare site by site. What do patients delivering at each institution look like demographically? What are their complications? What are their comorbidities? They could make choices about where they're creating their medical home, where they're spending their healthcare dollars. This kind of transparency for a state with as deplorable a history as we have was not only radical, but incredibly necessary. And wow, did it draw the attention of hospital administrators. So what I'm going to point out before we move to the next slide here, on the bottom right-hand corner, you're going to notice two of our outcomes measures. We have maternal hemorrhage with that ugly red up arrow, and we have SMM with an arrow going down. Also, throughout a form like this, our patients are able to see what resources are available to them. What hospitals are baby-friendly, have excellent lactation support? What hospitals have low rates of 3rd and 4th degree laceration? So a lot of information our patients are able to pull at their fingertips. Next slide, please. Okay, so While it was very distressing to hospital leadership and system leadership, Overlook's history of high hemorrhage rate among cesarean birthing patients was not news to us. I don't want to minimize the tremendous amount of work that's occurred in this space. We were doing the right things. We were utilizing pre-C-section huddles. We were measuring quantitative blood loss, using hemorrhage bundles based on ACOG's Safe Motherhood Initiative, updating them with AIM. We had high-fidelity simulation that was mandatory for all team members on L&D. We made it mandatory for anyone taking anesthesia call on the labor floor. And yet, despite all of this work, we weren't moving the metric. Every case of hemorrhage was reviewed at Overlook for trends, for anything that we could find systematically that had not supported that patient's care. Each of those hemorrhage reviews was reported out to perinatal quality and safety at a local level, and then higher up at a collaborative level all across Atlantic. And as you'll see, we went through, if we can click please, we went through and validated the state data. There should be a bar that pops up on the bottom. If our tech team can just advance or click. There we go, and one more time for me, please. Thank you so much. So we can see we validated our data from 2021 and 2022 with Atlantic internal data, and the state was right. And unfortunately, despite all of this effort, despite all of this energy trying to align our teams to best practice, defined by you, we really weren't moving the mark. So we're going to go to the next slide, please. Thank you. So with the release of these reports and a lot of anxiety coming at a system and a local leadership level, I found myself following one of my mentor's most valuable pieces of career advice, and that's raise your hand for the messy project. Raise your hand, step in, and start to build your team. So we pulled together a really robust multidisciplinary team. Previously, hemorrhage at Overlook had really been maintained insularly in the obstetric community. We wanted to branch out beyond that. We partnered with maternal fetal medicine, with hematology, with nurse leadership, with local nurse managers in our practices, with our Health Start clinic that serves our and underinsured patients. So we created this very robust, respectful, diverse team to try to break down what the root causes of hemorrhage at Overlook were and try to identify tests for change. Those of you in the room who are lean trained, you know that's some of the language that I'm leaning into. Lean methodology and anesthesia go hand in hand, so that's an easy place for me to start off with these projects. So you'll see that we created tests of change or interventions across the full continuum of maternal care, and there's two that I'm going to highlight for you today. Those are antepartum anemia optimization and the early recognition and management of obstetric hemorrhage. So we'll start with anemia. Next slide, please. Thank you. So why anemia? Well, anemia is one of the most common health problems that pregnant women face, and there is a strong correlation between antepartum anemia and the severity of intra and postpartum bleeding. CMQCC's Hemorrhage Toolkit identifies antepartum anemia as an important and potentially modifiable contributor to SMM. The most common cause, as we all know, of anemia in pregnancy worldwide is iron deficiency anemia. And as we discussed yesterday, iron deficiency anemia is a health equity issue. It aligns closely with social determinants of health. There are higher incidents of iron deficiency anemia among Black and Hispanic birthing communities. CMQCC and ACOG align very closely in their recommendations for early identification of iron deficiency anemia, iron store repletion, and the ultimate goal of achieving a hemoglobin of greater than 11 grams per deciliter by the time of delivery. New Jersey actually did us a favor as well. The New Jersey Department of Health report card included methodology, and in that methodology was logistical regression analysis identifying independent risk factors for obstetric hemorrhage. The odds ratio for anemia was 1.29, and while comparisons are a little challenging in this setting, that odds ratio interestingly exceeded that for preeclampsia, for obesity, and for Black race. The report card also demonstrated that our rates of anemia at Overlook Medical Center were significantly above the state average. So we had our first target for intervention. Based on recommendations from CMQCC and from ACOG, we knew what best practice looked like on paper, The algorithm is relatively simple, it's relatively prescriptive. We check a CBC and ferritin in the first trimester, again at 24 to 28 weeks, again at 32 to 34 or even 36 weeks. And there's fairly clearly prescribed actions based on laboratory results. This model had been utilized at our Health Start clinic, which had demonstrated pretty significant success, improving our outcomes for our most vulnerable patient population at Overlook. The challenge here, however, was not knowing what to do, but how we could achieve buy-in and standardization across a diverse obstetric set of practices that comprised Overlook and ultimately Atlantic Health System. These ranged from large multidisciplinary groups that were not owned by Atlantic, Atlantic-owned practices, midwifery groups, and a few solo practitioners who still remained within our catchment. We could literally spend hours or an entire conference talking about the process of change management, and I think a lot of us have touched on that during our comments here. But the bottom line is this: we needed to create a burning platform. As a team, we needed to provide and agree upon consistent language for why there was a necessary need for change and what the danger of the status quo was. This was particularly important for us because overwhelmingly at Overlook, our moms went home seemingly healthy. 40% of our hemorrhages were low volume, less than 1,200 mLs. Our transfusions were infrequent. Admissions to the ICU were quite infrequent. And our rates of SMM were well below those of the state average. We needed to have a compelling reason to get our obstetricians and our midwives, all of our collaborative care team to participate. So once we had achieved buy-in, then the team turned to tackling logistics. We went, and again, this is a small-scale project, we went to every single practice. We met with the practice managers, the nurse managers, who are the ones who are executing the mechanics of care, and we learned so much from them about barriers. There were barriers to accessing appropriate hematologic consultation. So the team went back. We partnered with Atlantic Health's hematology groups, and we worked on a pathway to execute and prioritize consultation for our antepartum patients. We also developed and provided to interested providers, both midwives and our obstetricians, access to care plans within Epic. It was a 1-hour training that they could take, and following the Atlantic algorithm, they would then be able to send their patients to infusion centers within Atlantic to receive intravenous iron, bypassing the need for hematology for our simple iron deficiency anemia cases. It took time, but as you can see in the graph on our right, our anemia rates are getting better. And I'm very proud of this group. They are actually the best in the system, and we've taken our roadshow throughout Atlantic's 5 delivering hospitals, and we're seeing systematic improvement that's benefiting our moms. So I'd also like to briefly touch on strategies employed for the early recognition and management of obstetric hemorrhage. As I mentioned before, we had some good structure in this area. We were doing QBL. We were utilizing the hemorrhage bundles. We had simulation. Thinking back to Elliot's talk yesterday, we had the toolkit, but the teamwork and the timeliness, they were a little bit lacking. Incidentally, when the release of the report came out, we also noticed an uptick in our hemorrhages for vaginal deliveries. So that kind of gave us the idea that we needed this robust response at stage 1, both for vaginal and cesarean. So if we go to the next slide, that's exactly what we set up to do. We took this opportunity to reassess our response to stage 1 hemorrhage. And again, these are not novel strategies, but when used consistently through a shared mental model, they are highly effective. In particular, the implementation of a huddle at 500 mLs QBL addressed those Ds that we heard about yesterday: denial, delay, and dismissal. These huddles can be triggered by any member of the team. And thinking back to May's discussion yesterday, by having any member of the team feel empowered to speak up and say, hey, I think we're approaching 500 mLs, let's call together a huddle. We improved team members' willingness to speak up, and we reduced that kind of psychological barrier by creating safety for them in that space. We also increased our resources by having additional RN and OB resources come to the bedside as this huddle was occurring. That reduced barriers to achieving extra assistance in the room because it removed the stigma for asking for help. Help was already there. So let's see, how are we doing now? We're going to go to the next slide. Okay, so anytime we're talking about state data, again, it's very slow. I have 2023, which is expectedly bad. We knew that that was coming. You'll see the long lines that are going to go all the way to 2025 year to date are Atlantic's internal data, and then we can see the state averages, which are below where we are. Atlantic had a significant gap in cesarean rates of hemorrhage, both in 2021, 2022, and 2023. But we're moving the mark in a really important way. We've reduced our rates of hemorrhage significantly for both cesarean and for vaginal deliveries, and we're moving in the right direction. We're also seeing this work moving more broadly across Atlantic Health System through the OB Collaborative and the Postpartum Hemorrhage Work Group, which many of our team members have stepped up to take leadership roles in. So it's been a great opportunity for us to learn within our local institution and spread those good learnings across the system. So I hope what you'll take away from my discussion today, and I did keep it brief, was not so much the road to reducing hemorrhage, though I am in for that work. I'm here to celebrate you. I appreciate the work that you do, and I'd love to partner with you in that endeavor. But rather, what I want you to consider is the role that our anesthesia community can play in teaming, in change management, and in process improvement. Whether you are an innovative researcher, a community provider like me, whether you're training the next generation of anesthesia providers, each of us is going to be integral to this journey of improving maternal outcomes. I'm really looking forward to our discussion later today, and I just want to leave you with, think about that project that you want to undertake, think about the team that you need to do it, and think about that burning platform, that compelling argument that you're going to disseminate to get those first followers. Thank you so much.